Begin. Yes, we've got the thumbs up. Okay, so I am absolutely delighted to welcome everybody to our annual Cicely Saunders International Lecture. My name is Catherine Evans. I am a clinical professor of palliative care and I am the director of the Cicely Saunders Institute. So just to say that this is an annual lecture. We have a fantastic opportunity to welcome international leaders in palliative and end-of-life care for them to come and talk and present their work. So this is very much a unique opportunity of bringing together our clinical colleagues who've joined us both in person and online, our healthcare researchers, policymakers and palliative care funders. So a really fabulous opportunity to learn together, to reflect and discuss, and for all of us to be improving the provision of palliative care to all, from children to adults. So I have to just do a few housekeeping bits, just to say that the event is being live streamed. There are around 300 people who are joining us online, which is fantastic. You can see on this holding slide that if you would like to be posting on social media, please do that on X. Please do use our hashtag as well for CSI Annual Lecture 25. After the lecture, there will be opportunity for questions. So if you have questions, as Professor Lieve is speaking, please can you email them at the csi.events@kcl.ac.uk. And then just a few other housekeeping. If you need the bathroom, it's through these double doors over here. We have no planned fire alarms, so if those go off, please follow colleagues in red lanyards and we'll direct you to the meeting point. And then finally, just to say, please do post your questions and answers. For colleagues who've joined us in person, please just be thinking about questions that you would like to ask of Lieve and for us to have a good conversation at the end of the lecture. So now I would like to introduce Professor Graham Lord. Professor Graham Lord is our Senior Vice President at King's College London for Health and Life Sciences. He's also the Executive Director of King's Health Partners. So it's with great pleasure that I ask Graham to welcome Lieve and to open the lecture. Thank you.
Thank you very much for your introduction, and it's great to be here opening the annual Cicely Saunders lecture for this year. I've been back in South London for about 12 months now, just over 12 months, so I did this a year ago after I'd just been in for a few weeks. And in fact, over the last year, I've seen just the fantastic work that's been going on here, so it's a real privilege to be invited to do this and to do it. So King's Health Partners, that I have the privilege of being the executive director of, launched our new strategy over the last 12 months, our strategy to 2030, with a clearly stated ambition to deliver a reimagined health and care system informed by people, education, research and innovation. And I can't think of a more pressing need in society today for us to address that question. It's a very difficult question. But within King's Health Partners, the palliative care clinical academic group housed at this institute makes profound and major contributions to our goal of joining mind and body for better patient outcomes. And I just thought I'd treat you to a non-exclusive list of brilliant achievements from the institute. So in innovation, we have our new Centre of Excellence for Paediatric Care, led by Professor Lorna Frey, Kent Town Support Charity. And this centre will drive innovations in care delivery and organisation to enable all children and young people to be able to access the palliative care that they require. All the time building research capacity in this very neglected field and set the standard globally for high quality research, education and care. In terms of policy, the new Impact Centre for Palliative and End-of-Life Care, led by Professor Catherine Sleeman, which has been funded by the Kirby Lang Foundation. Now, this centre, as I'm sure you know, is the first of its kind and will accelerate better care for people affected by dying, death and bereavement by closing the gap between evidence and practice. In terms of capacity, Build PAL is a 5-year programme at the Cicely Saunders Institute, building research capacity in palliative care by training professionals and practitioners to develop and deliver effective palliative care across care settings that's supported again by reliable evidence. And the programme is funded by the charity Cicely Saunders International through a private donor and charitable trusts and foundations. In terms of research, Better Health and Care Futures, which has been led by many in this room, particularly Irene, is a major research and education building programme. And this is a cross-faculty initiative across the entire university seeking to transform health and care on a global scale in partnership. And this year the programme very excitingly launched the Better Health and Care Hub that does link all the faculties across King's to generate interdisciplinary solutions to societal problems. Even further in the research space, the Hub is funding the Family Carers Project for people living with dementia at home, and that's led by Dr. Claire Ellis-Smith, enabling people with dementia and their families to access the right care at the right time and improve comfort and quality of life. And this project is part of the Empower Dementia Network Plus, which is led by Catherine Evans, working in partnership with communities, public members, practitioners and researchers from across all of King's faculties to address the worst inequalities in dementia care for people needing greater support. On the clinical side, the palliative clinical teams from Guy's and St Thomas's and College Hospital continue to provide outstanding specialist palliative care 7 days a week, 24 hours a day, managing highly complex care needs for patients and families, supporting them to live well and die well, progressive cancer and non-cancer conditions. So the annual lecture today is being delivered live and beamed out to the rest of the world from the Cicely Saunders Institute at King's College London. And it's my absolute pleasure to introduce Professor Lieve van den Blok. Did I get that good? Professor of Ageing and Palliative Care, Director of the End-of-Life Care Research Group of the Vrije University of Brussels and Ghent University in Belgium, and the founding chair of its Ageing and Palliative Care Research Programme. And Lieve has a background in medical, social science and clinical psychology, and has been a leader in palliative care and end-of-life research for over 20 years, focusing on national and international public health and interventional research, notably innovating palliative care for older adults with serious illness. You lead the EU Navigate programme, supporting older people with cancer by developing a navigation system aiming to improve the quality of life and well-being by promoting timely and equitable access to health and social care services for patients and their families. And as if that wasn't enough, you also chair the Ageing and Palliative Care Reference Group of the European Association of Palliative Care. And today she will talk on the future of palliative care in an ageing society, evidence and practice. So Lieve, over to you. Thank you.
Thank you so much for that kind introduction, and hello everyone. It's a real honor for me to be here. A luxury also I feel to be here in person because many of the events are online. I also welcome people online and I need to move a little bit. In this way you can hear me well, I'm hoping. So, I'm hoping to talk to you a little bit more today about the future of our field, palliative care, in an aging society. We all know societies are aging, but what does that actually mean for us and for palliative care? Have we thought that through well enough? First, I'd like to introduce our research group. It's a really vibrant, enthusiastic group of people who work in 2 universities in Brussels, in Belgium, as was said, the Vrije, the Free University of Brussels, and Ghent University. I chair this group together with my professor, my colleague Professor Joachim Cohen and Kenneth Chambara, and it's amazing what you can do as a team together, I think. My own research dates back a little bit more than 20 years, and I've always had a particular interest in aging, dementia, frailty, nursing, homes. In the beginning, we did a lot trying to describe how people die and the type of care that they can introduce systems to monitor this better. But over the years, we've of course also tried to change things and to think about interventions that could improve and understand what we're actually doing to go into practice. We have large grants in care homes or nursing homes, we call them in Belgium, in England, but also in hospitals, in communities, at home, of course. And most of our research is open access, and you can find them through our PhDs on our website. So that's why I put the website here. We really strive to have everything open to the public and to professionals. So I'll draw a little bit on this research from the past and also a little bit on what we are currently doing with a look towards the future. And I brought today two main parts, I would say. One part really standing still at the question, what are older people's needs and what are their priorities while they die, but also while they are living, because dying is a part of life. So what do people need from a perspective of things that go wrong, but also what are their priorities, what matters to them, which might be something else. And then secondly, if we really want to address needs and priorities throughout this life and death course, you might say, how can we then do that alone? I don't think we can do that alone as a palliative care field. We really need to cross disciplines, but not only disciplines, also sectors. And that's what I'll be talking about today. So the first one, the needs and priorities. Now, I was thinking in advance, should I give some key facts on aging? Well, you can't give a lecture on aging without giving some key facts. And a first fact I really want to stress is living longer is a success story for society. Most of us in our field, me, myself included, and our researchers, we start our publications with saying how big the burden is of aging or how many problems aging creates. Aging is a success story, and that is also something we should recognize within the palliative care community. The figures are clear. By 2050, we have 3 times as many people older than 80 plus. So if you are in the middle of society, you will meet 3 times as many people who are 80 plus by 2050. If they are, of course, part of that society. This process started in high-income countries, but definitely it is now also experienced in low- and middle-income countries, so it's a global challenge. And of course, you know this, the proportion of life in good health has remained quite constantly. So that means that people, the additional years that they get is sometimes in poorer health. And that's, of course, where palliative care comes in. And it's really good, I think, when you look at the healthy aging community. So I don't know if you know this, but we are living a decade of healthy aging. So the United Nations called this the decade of healthy aging. Their motto is adding life to years. Well, that's also the motto of palliative care. But strangely enough, palliative care, end-of-life care, dying is not part of the healthy aging agenda yet. So I was very happy to see movement towards that. Rowan Harwood, for example, led an international team looking at measuring and monitoring quality of dying in the UN Healthy Aging Decade, because dying well, of course, is part of aging well. So things are moving slowly in terms of these fruitful collaborations, but it's really a necessity. From both angles, I would say, from the palliative care towards aging, but also from aging within palliative care. I promise this is the last slide where you will say, oh no, those trajectories again, but I do feel I need to show them to you because we have to be aware the general end-of-life trajectories that we present so often, they also apply to older people. And I would say more specifically, in reality, it is a combination of all of these for many. So some might die seemingly suddenly from an acute illness. Some may have frailty, but a whole lot of other serious illnesses, we know this. But that means that sometimes people can have problems or issues for years. And that's very different. To think about palliative care in terms of years is very different than thinking about palliative care in a terminal stage. And you can't identify terminal stages, you can't identify dying. So I know you all know this, but still, what does that then mean? So how can we change as a community to really address this whole trajectory? So what do we know? What does the evidence say on throughout this trajectory? What are the different needs and priorities? And there's a whole bunch of literature out there. I've only included a number of publications here from my own team, but also from many of you here. Some really interesting reviews on what are palliative care symptoms, for example, what are concerns of people, what are their needs when they live with frailty or advanced frailty, when they have multi-morbid diseases, etc., or cancer. You know, there's a really big literature on needs and palliative care needs. And the usual suspects, if I would summarize them, come up. Multidimensional. Functional aspects are really crucial in old age. It is something we talk about in palliative. Physical, of course, psychological, emotional, existential. These issues and needs and problems really come across the literature, but what's also interesting, if you specifically look at older people, it's the social issues and the issues. So loneliness is a really topic for older people who cannot go out really easily. But also practical. It can even be as simple as getting out for groceries. It's not always high-level problems. And then the combination of all of these. And what's also interesting, this is really the literature or the needs that we are used to seeing in a palliative care population. And it's also the way we have learned to think, I think, in terms of what does a person need, what are their problems, and can I address them? But if you look at whole other type of literature, namely what are people's lived experiences when they age, when they have a serious illness, what are their perspectives on their life and the way they live their life and how care comes into their lives, or when you screen the literature for what is important to you, what are priorities for you, what would you say is really something that matters to you, you get a much broader range of domains than the ones that I've just come to list. I've put a number of papers here, some of them still in the making, that really focus on a whole, sometimes different domains than the needs-based focus that I've just presented. And I try to summarize it somehow in some thematic analysis, but this was done quick and dirty. That was me. So, if you look at what matters to older people when they develop serious illnesses across all of those trajectories, it's daily living. People want to have a meaningful daily life. They want to do things that are interesting to do and that are nice to do. They want to have the good conditions in everyday life. What also comes out really strongly is continuity in life. So that means being able to maintain your own roles. If you were a caretaker of someone, you want to still be a caretaker. If you are someone who, grandchildren, for example, coming over, you still want to fulfill those roles. So continuity in your life roles, but also, of course, continuity in care. Having to explain yourself every time again to new people. Not having too many people coming into your home all the time, yet another one, and people don't even know any longer from which department or setting they are. That applies to palliative care too. So what matters to older people? Independence. Being independent, being able to walk around, being mobile, to do the things that they love doing and that they've used to be doing, to have some control and freedom and some say in the matter. And why I think this comes out really strongly is because often in society there is not much room for them to have this. society pushes back due to ageism or ableism, and that's why these themes come to the forefront to people, because they feel the restrictions when they go older and become immobile, for example. They also want respect, dignity, they want to be seen and heard, and some sense of meaning. Social connection is a theme that comes out very strongly in the literature. Meaningful relationships and being able to maintain them, the need to give attention to their family or unpaid carer is also something that they stress a lot, because it's not only about them, it's also about the effect that you have on your caretaker or on your family. And then, of course, what I said, the practical support. Financial issues might also be really, depending on the region, might also be really very worrying. We saw the slide from Sarah with the bunch of documents there. It can be exhausting to get your head around those. People want to stay close to home and avoid hospital as much as possible. And then, of course, you have the literature going into the physical, mental, spiritual needs. And the more you go into the literature into end of life, but I'm meaning really close to support for the family. This is all for them, because when you grow older, you lose many people in care homes, but also in the community. Actually, a lot of your life is centered around loss of independence, loss of social connections, loss of a sense of meaning. So this is really something that comes up as an important topic. And then finally, security in care. Feeling safe, trusting care, it was mentioned earlier also. This is a big issue for older people, especially if they go in and out of different services and hospitals. Who can I trust? Who's the person who will be there and advise me in the best way possible for me as a whole person, and not just for this disease or this specific condition? So I think when we think about palliative care and what we can offer, we should offer this, what matters to people. And it will differ, of course, throughout the trajectory and from person to person, but these are the things we should be thinking about, working on, creating interventions that support these topics. And for now, I think many of our interventions are not yet doing that. We are still focused a lot on a needs-based approach. But what matters most is more than dying, it's living a good life. It's more than the medical, physical. It's this whole person who has had a whole life already. And it's more than the needs or health-related quality of life, which we often measure. In many of our outcome measures, we talk about health-related quality of life and needs, which is very important. You saw that in one of the topics. But it's also about well-being, supporting abilities, supporting people to get up and about, for example, to live a meaningful life. So what about those outcome measures for this population? That said, I said it was a quick and dirty analysis. I feel there are a lot of research gaps in this literature, especially the ones that look at demands a longitudinal design. And I'm very happy that Lara Pivodic, for example, from there are lots of different underrepresented groups that this research still needs to be done with, because I know sometimes you feel I need to change things, but you also need to start from a good idea of what you need to change. And for that, you have to go back, in my view, to what people are telling us. And that is a whole lot of things when you grow old. And secondly, a global perspective for me is missing. I just found this paper from people here at King's, I think, on primary palliative care for people in multimorbid serious illnesses in sub-Saharan Africa. We need a lot of these studies because if you look at them, the needs, for example, like practical or social or financial needs, they come out of this literature. So if you want to build a framework, a conceptual or a methodological framework that really will support all the people across the world, we need to also have research there. So that said, how can we now meet these needs and what supports what matters across the trajectory, and where is our role as palliative care? We know there are many, many different sectors and disciplines. I've only listed here a few, and I didn't forget the unpaid carers, of course. The social sector, the voluntary sector, many, many people are all working towards a better life for people. I truly believe most professions go into the profession to make a change. So how can we actually create a system of collaboration or joint engagement to support people? And I've brought to you a number of examples where I hope you can find some more inspiration, but it's definitely not a fixed answer. It's more an open invitation, I would say, to think about this further. And I explicitly chose this picture, the Squinty Bridge of Glasgow, because it crosses the river at an angle. It doesn't cross the river straight. And I think that is what we also need to do. Be a little bit squinty. I actually didn't know that word before I gave this lecture, so I'm hoping it's not a terrible word. So first is on frailty. We did a few years ago an international collaboration to really think about frailty and how we might develop a white paper on what palliative care, that's how it started, what it could look like in frailty. And we sat together with a number of people from different disciplines. While we in the beginning said we want to introduce palliative care earlier and we want to develop a palliative care approach for people with frailty, after a couple of meetings and thinking, we came up with another concept, and I know it's a long one, but it's very important in our feeling to say it's not only palliative care, it's also other disciplines. And so in this white paper, we said we want an integrative approach, integrative, palliative, geriatric, and rehabilitative approach to care and support. So all of these words were carefully chosen because it's not only about care, it's also about support and bringing it all together. So we tried to bridge these three disciplines. We reviewed a lot of literature in these three disciplines. And then we did a Delphi study. Many of you might have participated. Well, we carefully selected people from different countries specifically so we could have a broad set of professionals, but we also engaged with older persons representatives, for example, from Age Platform Europe, which is an older persons organization, to also get their voices. So in the end, we had 28 countries. We had 34 recommendations. I know this is a lot. Under 11 domains. So guess what? I won't present the 34 recommendations to you today. You are lucky. But we really try to capitalize on the strengths of these disciplines. So palliative care is really good in the needs part. Geriatrics is really good in the thinking about physical activity, about geriatric assessment, comprehensive geriatric assessment, etc. And rehabilitation is also really specific about goal-oriented care, preferences of people, and also more the capacity-based approach and not the needs-based approach. So bringing that all together, we came up with a framework that focuses on clinical aspects, health service aspects, and public health perspectives to address all of these issues. That's why they are so many. And we explicitly also chose to name it integrative and not integrated because it's more than setting a structure so you are integrated. It's really integrative and active principle of combining, dismantling silos, unifying and making a whole. So we really wanted to say palliative care has something to say early in the trajectory, but rehabilitation has also something to say at the end of the trajectory. And that was important as a basis for this work. So these are the different domains. I won't go over them for time reasons, of course, but it's all published in the Lancet eClinical Medicine a couple of weeks ago with a lot of appendixes, a lot of literature for you to read and discover, because we also discovered really nice work outside of the field of palliative care. So an invitation to go and have a look. And then lastly, from this part, from this work, we also asked our panelists who came up with a number of recommendations by themselves, but in a second round to rank them. And these were the ones that were really ranked very highly. Continuity of care, that came out strongly, that we lack evidence. This includes outside of working hours, but it's also more about much more than that. Implementation research, because you can say how it needs to be done, but how do you actually do it? Maybe you should de-implement some things, but how do you do that? Effective components, what is actually things that work and what doesn't work, and maybe we could learn from practices that are doing it really well and compare, for example, and come up with what makes a difference. And then a very specific one on nursing and care homes to really transform those, because there also we have fantastic initiatives, for example, combining rehabilitation approaches with palliative care approaches. You can find them through the literature, but also through films, for example, about fantastic care homes for people with dementia, for example. But how do you transform a whole sector that's not used to working like that? This is a huge challenge. I won't be talking about that today. That's for a next talk. But it's really important, I think, to not forget our care home population. So a second example of collaboration is also linked to work that King's has been doing on timely integrated palliative care models for older people. This one is one of the papers colleagues have published on supportive care intervention. You immediately see it's about integration. It's not only about palliative care, and it's community-based. So sometimes it's very difficult for understand a system. So when you read these papers, you get an idea of the system and a flavor, I think, of the intervention, but still something very difficult to fully understand it. So what I've understood, but correct me if I'm wrong, it's really integrated working between specialists in palliative care and primary and community care. So GPs and community nurses who are used to working together, where a specialist palliative care comes in. At points where there is increased suffering, so a sort of additional layer of support when it's necessary. So start it up early enough so you're there when it's necessary. This was a trial with really great outcomes, reduced symptom distress, medium effect size, cost effective. And I also liked the inclusion of the mixed methods. It's not only about this primary outcome, it said things like little things make a big difference and care beyond medicines, which really enriched the paper in my view. In Belgium, we also tried this. We called it the Frailty Plus intervention because the plus stands for using theory of change to understand what do we need to do, how do we need to do it, and why. But we built on the SIPS model and tried to implement it in our healthcare system. I learned today there are lots of differences between our healthcare services and yours and the way it's been set up. So Frailty Plus was really welcomed by, we did a pilot trial, by the way, not a full trial, because we felt that was so different in our case. So it was really welcomed by all the people and their families. They got a visit, a home visit from specialist palliative care nurses. But we came across multiple implementation barriers, and they for us are rooted in our system. So our palliative care teams are really used to working in terminal end-of-life situations where they can make a difference in an acute setting. It feels like solving acute needs. Well, this population is a totally different population, and even though that we discussed that for a number of times, it's strange for a specialist palliative care to go in and to see a whole range of different problems which they feel they cannot solve, for example. So beyond timely referral, organizational and cultural change is really needed in our country, and you can't just take one intervention and try to duplicate it in another. Additional thinking about how the system works. We can discuss that if you, because there are a lot of differences. But the third example is something that I add as a last possible evolution further upstream, beyond this healthcare perspective. And I've called it social and community support models of palliative care, but I think there are a lot of different terms you could use. It is stepping outside of the health service perspective alone. And so I've been looking at a lot of literature on this. I could have probably chosen a number of others, but these ones I really wanted to highlight because I feel they can be used in many different settings. They are adapted in many different contexts. They follow a palliative care approach, but they're not always called like that. We call them navigation interventions. Some people call them compassionate community or connectors. Others call them lay person working or volunteer programs. The ones that I've picked are programs that really support a person throughout their trajectory and not at certain moments in time. Because you have a lot of volunteers, for example, going in at the end of life only, or specific navigators looking at breast cancer screening, for example. They go in or they have a specific task or role. These are really navigators that support people throughout their trajectory. So the one from Samar Aoun from Australia, for example, Compassionate Connectors, showed in her region an effect on healthcare use. It's one of the interventions that has most evidence, I would say, from our field. The second one is from Kerala, India, where I think that a lot of community work is done. And I think in London, the compassionate neighbors are based on this work. And then the right one is from the States, the Enable trial, also uses led interventions in African American and rural dwelling populations. That's a trial that's still ongoing, but really all very interesting things. And it links a little bit to our intervention, which I would like to talk to you a little bit more, and that's EU Navigate. It's a current project that we're currently still working on, so I have a little bit of data, but not much. We want to implement this navigation idea or connector idea throughout this trajectory. We focused on all the people to the call of the EU. It wasn't my direct choice because I feel these interventions, you can really do much more than just with cancer. It's an international pragmatic RCT, lots of data, process evaluation, and Peter May doing the cost evaluation. So we have Canada on board, Ireland, Poland, Belgium, the Netherlands, Italy, and Portugal. So it's a 6-country trial with a Canadian partner. This is a picture of our last consortium meeting and the collaborators in the project. And I also always find it important to say that it's usual academic suspects, I would say, but it's also, for example, cancer charities that are on board as a partner and implementing the navigation intervention, for example, in Portugal and in Italy. And that's really an addition to the consortium. So it's a multi-site, pragmatic fast-track RCT. Why did we choose that? Because everyone gets the navigation. Just one group gets it immediately after baseline, and the other group gets it 6 months later. So it's really a long trial, a long period. And on top of that, we follow up people for at least a year after the navigation starts. So we promise people that they have a navigator for a year. But if afterwards, for example, that navigator wants to continue and the client wants to continue, that is a possibility that's discussed within the context of the local community that's implementing it. For our trial, we're looking at 70 plus people who have cancer and declining health using the clinical frailty scale. And we also want a close family care if there is one. So that is someone living with the person or maybe living close by that they can visit regularly. I would have chosen 5 or 6 primary outcomes, but alas, most of the time you need to take one, but at least we got 2. 2 primary outcomes: global health status, quality of life in general, not symptom specific, and social support. So really feelings of emotional support, practical support, and social support. We follow them up and really thorough process evaluation, understanding how they implement it, but also understanding the contextual factors that are of influence there. So that's why we use the PRISM framework, which is a really nice framework to do more care. It was developed by Barb Pessut and Wendy Duggleby in Canada. They have a lot of, I think, 15 years of experiences rolling this across different districts in Canada. And it started with them an adaptation process. We've published this because we felt it was so intensive to do. You know, you have an intervention that works somewhere, and then you need to think, how will we do this in 6 other countries? And you know, the same way, the differences in the healthcare system. So we used the ADAPT guidance for that, which was really helpful, thinking through what is core, what do you really need, and what is optional. And there are a lot of things which we have called discretionary components, especially in the implementation part. So what do navigation interventions do? They provide navigation through the system. They are specifically made to tackle inequities in access, especially if you have navigators from the communities that might experience inequities. But central are their roles. I said so, they are called different labels: connectors, linked workers, coaches. You have a lot of different terms for that. But what is really crucial is they work from the relationship. So they don't go in with a list, for example, to assess needs. They go in to have a talk and to build a relationship. So it's from the relationship that financial or social or practical needs come to the floor. They don't come immediately. You build trust. And it's also reciprocal. So it really works in the relationship also means something to the navigator. And that's why matching them and really thinking about what is the boundaries of your role is so important in these interventions, and they fit really well with the compassionate community approach. So I won't talk to you about that, but often compassionate communities have lots of different activities. This is one you can really do if you really seek those patients that you normally don't catch. If you think about caring neighbors, for example, caring neighborhoods, those that are most vulnerable are often not reached. So reaching out to them through navigation is one of the interventions you can do in such a compassionate community. So as I said, they are trained, mentored and supported. That is really something I want to stress. They sit together monthly, together with a coordinator who addresses their role, their worries, and they learn by doing. So it's not a 1 week training that they get and you send it off. It's really learning by working in the relationship. So they connect people wherever and whenever they can to services, focus on advocacy, empowerment, and think of the question, what is most important to you today? That's what they train to do, to go and ask, what is support? So they are embedded in existing organizations, for example, in Belgium in a primary care network, and on top, because this is the triangle of the links to the community, for example. I didn't say that, but it doesn't have to be a specific to join a card club. Sometimes people have needs that are not really addressed by professionals. So it can be all sorts of things in communities people don't even know about that exist. So the idea really is that a navigator links them to them. But the navigator doesn't have all that information on his or her own mind. That's why they also have these coordinators. They are really linking everyone in the system, trying to map what is out there, and then advising also the navigators on what they can do if they pick up on something. So it's really a dynamic system, I would say. And that's why I like this intervention so much. It links the ecosystem around the person. Many of our organizations are sitting together now with people they have not sat before. So working on a project together creates links in the ecosystem that were not there. And that makes it so interesting, and it's much more than an individual intervention, I would say. Including palliative care. I haven't talked a lot about palliative care, but of course the idea is if they need specialist palliative care, that's why they are trained to pick up on palliative care needs, to discuss death and dying, to not be scared about when people give you balloons on, I saw Magda from next door, this and that, and what does that mean to you? So it's really a combination and integration, I would say, of all sorts of approaches, including palliative care. Here are a few publications of our own, but also of Wendy and Barb, who did marvelous work in Canada. I also brought a little bit of data, but not much. These are the number of clients that I currently have. Importantly to say, I've estimated it for now, but we need to look at it. Over half of the patients we approach decline. Not because they don't want to be part of research, don't want another person in their house. It's very important to understand this is not something for everyone all the time. Currently, we have a pool of about 100 navigators, not only old persons, also younger in Belgium, one below 20. What do they do? Provide practical support. Some examples here. Emotional support, the grave of a late husband together, and social support. Go out for coffee, someone to talk to, help me do some activities in local community center. So it's really about symptom control at this point when we look at the diaries. We're currently looking into these models for all other types of populations. I do feel that, but to sum up, because I got the signal, the way forward, it's just one slide. I thought I could talk for probably another 30 minutes about it, but I wanted to sum it up in this way. So if we really want to address needs of people and what matters to them, then across their trajectory, then I think we can do a lot at practice, policy, and research level. For practice, I think palliative care should lead this fundamental change in the care ecosystem. We have been in Belgium too for a long time looking at specialist palliative care and getting our skills out there to the GPs or to others. But it's really about acknowledging there are lots of strengths in the system, not only in palliative care. So bringing that together, connecting, that is something we can lead on. For policy perspective, there also the connection between policy frameworks is crucial. You probably have a lot of them: integrated care, aging, dementia, long-term care. Policymakers don't always connect themselves, and we know from our research often palliative care is not included in aging policies or the other way around. So working to connect these policy frameworks and prioritize the whole life course, the end included, is for me really something we can work on. And then for research, considering this becomes very complex with all the persons involved and all the different services, and it's also adaptable because things change while you're working on a year's project. So our evaluation methods must also evolve to capture that complexity and to acknowledge this need for participation. And we can talk, I think, a lot about what possible areas for new research methods might be to capture that. So thank you very much.
Fantastic lecture. Thank you so much. Very, very inspiring. I think exactly what we wanted, to feel enriched, understand more from colleagues from across the globe. For a couple of questions. Maybe I'll just take them in the room first. I'm looking to see if there's any online. There are. Okay.
You have to stand.
Thank you. Okay. I'll just take questions in the room to begin with. Yes, Sabrina.
A mic.
We got a mic. It's here. I've got the mic.
You'd like to just introduce yourself, Sabrina? Thank you. Sabrina Arjois, I'm a clinical reader here at the Cicely Saunders.
Sorry. Sabrina Badger, I'm a clinical reader here at the Cicely Saunders Institute. Thank you for a fantastic, amazing lecture. Very much enjoyed it. I just wanted to you were talking about the community connector, and you mentioned that there was 50% refusal rate. I'm just aware that here in the UK we have certain groups that we haven't yet managed to reach for palliative care, and they are, you know, to name a few, are ethnically diverse population, socioeconomically deprived population. And I was just wondering if you had any demographics of those people who refused.
Well, because of the fact that they refused to take part, we couldn't really register their characteristics. But I do know, if we don't connect to local communities and have navigators and connectors and organizations working with communities, those deprived groups you are talking about, we will not reach. In my view, the whole connector idea or the navigation idea is, if you want to support people in their communities, you have to work from the communities. So I think we are definitely not reaching a lot of people in our trial, where we had a lot of limitations in terms of language and inclusion criteria. But the ones that we are reaching is not necessarily linked to social deprivation. It's more, I think, about being overwhelmed already with the system. Many of them also you find in hospitals when they go home, so their problem is fixed at that time. Many older people don't even want cleaning personnel in their home because they come in at times that you don't want them to come in, or a care assistant. And then we are there with a study with a navigator. So I do feel if you would work in a community where this is more standard practice, like in Australia, where they're beginning to develop that, then that will be a way for people to ask about, can I have a navigator? While now we are, of course, in a system where people don't know about it. Yeah.
Okay, thank you. I'm just going to turn to a question that's come through online, which says, you've discussed in detail what matters to people. How do we elicit what matters most to individuals, our patients, our family members, and how do we ensure palliative care services are addressing these?
That's the big question. No, thank you. A wonderful question. Of course, I do feel you have to ask people what matters to them, but asking that in the same way all the time to every person that you come across might not work. So developing a language is also even a dialogue to learn. And you pick up on while you build a relationship. So I don't feel I have a prescriptive wording of a phrase you could use. I would advise against checklists. I do feel we were talking about the medicalization also of palliative care. If you come to people with checklists, you think it's only about what is on that checklist. So it's really about not using the checklist, but you have it in your back of your mind somewhere. So you know I feel something about practical needs. So you will see from within the relationship that it comes on the table. So in terms of what palliative care services can do, I really feel as a service, you can lead these types of initiatives to work in a different way, to link to your community, like the community hospice that changed their names towards community hospice. So it's really, when you have the luxury, especially in the UK, because you are often not as regulated as in Belgium, because you have a lot of charity going into your hospice. So that means you have a lot of luxury also to innovate, I would say. Maybe I'm wrong, but ours are so overly regulated that it's difficult to come out of your shell. So I would definitely say work towards these types of models and build together in communities new ways of thinking. Yeah.
So we've just got one more question. We're just about at time. So one question, then a question from colleagues who are joining us online. To say, you talked a lot about communities and interventions that involve trained support volunteers. Mm-hmm. How do you identify sites with existing community networks that benefit from community engaged interventions like the EU Navigate?
It's a good point. I also know from Canada, for example, that some of the communities that try to do NavCare in the end stopped doing it. So I don't think there's a size-fits-all for everyone. But if you don't go into communities and talk to people, you won't know them. So as you also said before, it's often about leadership, people you can work with, people that you like, that work from the same principles, with the same heart as you do. I would start there. Yeah.
Thank you. And any final questions from the room before we... Okay, Peter? Do you want to introduce yourself, Peter?
Thank you. Good afternoon. Peter May is my name. I'm a health economist here in the CSI. Thank you, Lieve, for a great presentation. I was wondering, when you were concluding there, talking about the practical, the social, the emotional aspects. Yeah. I can totally see that from a research point of view, from a care point of view, we want to care about those things. And what I was wondering about was who, from a sort of government point of view, funding point of view, is responsible for those things. Say in EU Navigate, we find a fantastic effect on loneliness and emotional functioning. If we have a drug that works, then we go to the Ministry of Health, but there isn't a Ministry for Social Connectedness. So how do you think about that? Well, maybe that's the answer, but how do you think about that challenge?
Yeah, from an international perspective, there are a lot of differences between countries in the administrative part behind politicians, for example. So in my country, I would definitely say I'm going to number of groups where I know they will be interested in. We have a big reform now on palliative care that started from the primary care field responsibilities in policy. So I would go there. But if you say there is a big social department that's really interested in getting it, doing things better for people with serious illness, or focusing on dementia, for example, I would say go there. So in my view, working with policy, maybe Catherine would say it otherwise, but it's really about seeing the opportunities that are there and trying to link your ideas to the opportunities that the different departments have. And then connecting, engaging, it takes a long time, in my view, to change policy. Maybe economics will play a part, but not always. I've learned that.
Okay, so I think we're going to finish our questions there. I would like just to give a thank you to Lieve. And then I'd like to welcome Kate Kirk to close our annual lecture. So Kate is the chair of Cicely Saunders International, a major and important charity for us in the Cicely Saunders Institute. So Kate, can I hand over to you? Thank you. Thank you.
Thank you very much, Catherine, and thank you very much. It was a fascinating lecture, and my goodness, we've got... I was particularly taken by this... I know you didn't want to show too many facts and figures, but this idea that by 2050 the population of people over the age of 80 will have tripled from what it is now is a bit scary, and I'm going to be one of them, so make sure it's ready for me. Priorities, that's an important topic, and I know many of us have thought about these different things and how they all interconnect over time, and I think you helped to highlight that actually are so many of them, and actually fitting things together, which is part of what goes on here in the Institute as a multidisciplinary institute, is going to be so important going forward, and we're going to have to possibly invent new ways of looking at these things and new ways of studying them in order to understand them better. Connecting policy frameworks is yes, Catherine Sleeman, you've got some work to do there, haven't you? Yes, good luck with that. And something that you were talking about care homes and the involvement with care homes and how the system there is obviously different. A phrase that we're hearing now here is that care homes are, in a sense, the hospices of the future. And so working with care homes and integrating that into a lot of the things that we do is also going to be critical. I could go on. I mean, there's so much in there, but I will just say thank you. That was a wonderful talk. Just quickly, so for those of you who don't really know about Cicely Saunders International, the charity, obviously we have the same acronym as the Institute. We've been around for just over 20 years. This is quite neat. So we've been around for over 20 years. We've raised over £20 million. And a chunk of that was obviously to create this institute in partnership with King's. And we've roughly doubled that, so another 20 million odd, in specific grants and funds for particular projects and particular aims. So this partnership and this unique sort of globally renowned institute has come about through integration and interconnection and being multidisciplinary and goal, and we'll have sorted it out by Christmas. We're incredibly inspired by everybody who works here. We're incredibly inspired by the people who come to give and show us some new ideas and perhaps chivvy us along with our thinking. Graham mentioned Impact Centre, PAL, dementia care. You can see how many different areas we are dealing with and looking at here. And that the charity is supporting in as many ways as it possibly can, mostly with money, obviously. That's the helpful thing. There are plenty more things to do. We have an action plan, and ultimately, in the end, it comes back to a lot of what you were saying, Lieve, that everything comes back to patients and their families, because they are the heart of everything that we do. So, without further ado, obviously, tea and cake and nice things are waiting for us in the atrium. So thank you very much, everybody, for coming. Thank you very much, everybody online, for joining us. And we'll see you next year. Thank you.